thank you very much for joining us. Before we get into the event, I would of course like to acknowledge the COVID-19 world that we are all living through. None of us could have foreseen the uncertainty, the unknown territory, and the inevitable restrictions in doing so many things that we've always taken for granted since COVID-19 descended upon us just over a year ago. The knock-on effect on our personal and professional lives has been and continues to be immense. On the professional side, I know many of you who are with us this evening are working across the world to prevent the spread of the virus in primary care and in public health roles, to care for patients with the virus, also in primary care roles in hospital settings, across many different specialties including infectious disease, microbiology, respiratory medicine, intensive care capacities. Many of you are driving research into more effective treatments for the virus and helping in the development and rollout of vaccines. So we acknowledge the challenges you are all encountering and the pressures you're feeling, and we wish you the very best with all of your incredible efforts that you're making in tandem with the rollout of national vaccination programs, which provide some light at the end of the tunnel. So we thank you sincerely for these efforts, and that we can eventually deliver a world where COVID-19 exists as part of the normal landscape of human disease, where we live with the virus as an endemic as opposed to our current pandemic. So on to the business of the evening. Just as a reminder, our Medical Graduates Association was founded in 1988. Today, the association works in close partnership with UCD Alumni Development Office to offer a platform so that you can keep in touch with your fellow alumni across the world and with the university. The association's main aim is to offer graduates the opportunity to build your professional and social networks and to maintain old friendships and contacts. And we are proud to say that our Alumni Relations Office currently has 4,500 UCD School of Medicine graduates on its database. So please consider that the MGA is your association. It exists to help you maintain contact with your contemporaries and with the school, and to help you avail of the many services that do exist for UCD alumni. It offers graduates the chance to have a lifelong link to the medical school and the university, and gives you an opportunity to influence the school's future. So on to our new MGA Distinguished Graduate Awards series. These awards are presented to outstanding alumni in recognition of lifelong achievements in medical education, research and/or clinical practice, and in appreciation of the drive, leadership and commitment to make a difference in society, both at home in Ireland and abroad, that has been shown by these outstanding alumni. To celebrate the success and contribution of our most distinguished alumni worldwide. Traditionally, these awards are, of course, presented on a face-to-face basis in the O'Reilly Hall on the UCD campus. However, given the current restrictions, we had to take a decision before Christmas to move to running these awards as a series of 3 virtual events. Our aim is to still try and offer you the usual reunion and memory type feel as we present these awards virtually. I'd now like to introduce you to Dr. Paul O'Byrne, who's the first recipient in this MGA Distinguished Graduate Award series. Paul graduated from UCD in 1975. He's currently the Dean and Vice President of the Faculty of Health Sciences at McMaster University. His research interests focus on the mechanisms and treatment of asthma, and he's published almost 500 peer-reviewed papers, has a H-index of 115. Paul's accolades include the James Graham Award of Merit of the Royal College of Physicians and Surgeons of Canada, election to the Royal Society of Canada, award of the European Respiratory Society Congress Award and Medal, election to the Canadian Academy of Health Sciences, and he's also McMaster's Top Academic Award, which is Distinguished University Professor. In 2017, the American College of Chest Physicians named Paul a Giant of Chest Medicine, and most recently he received an Honorary Life Achievement Award from the Ontario Thoracic Society. Good evening, Paul. You're very welcome.
Good evening, Michael. Very nice to see you, and thank you so much for such a generous introduction.
Good, and we're delighted that you're joining us virtually. Obviously, as I said, we would love to have done this in person, but we will, once travel resumes, welcome you to the campus.
I look forward to it immensely.
You graduated from UCD in 1975. Can you tell us a little bit about your time in UCD and in Earlsfort Terrace, which is where the medical school was in those days?
Yes, of course, I'm happy to do that. So I had a little bit of an unusual way of getting into UCD, Michael, in that I had emigrated with my family from Ireland to what's now Zimbabwe when I was a very young child, but came back to Dublin to finish a couple of years of high school. I went to Terranure College for 2 years, and then applied and got into pre-med, which at that time was in Belfield. I think maybe we were one of the very first classes in Belfield at the time. And then, of course, after that, managed to get through that ordeal and get into First Med, which at that time was indeed held at Earlsford Terrace. So together with the rest of my classmates, that was where we spent our first couple of years of preclinical training in medicine at Earlsford Terrace. Those were very interesting years. I was very fortunate when I left Terranure College. I had a couple of close friends who came with me into pre-med. Brian Lamont and Declan Herbert were two that I remember very fondly, and it was a tremendously collegial and enjoyable class of colleagues that went through medicine together. Of course, at Earlsford Terrace for the preclinical part, and then following that, the clinical training in the various hospitals across the city.
And Paul, where did you do your clinical training? Were you in St. Vincent's or the Mater, your res year and final med?
Yeah, so I was at St. Vincent's for much of the clinical training, some of it at the Coombe Hospital for the obstetrics and gynecology, pediatrics at the Children's Hospital in Crumlin, but virtually all of the rest of the training was at St. Vincent's.
Okay, and then when you graduated, you spent a little time as a junior doctor in Dublin. Can you tell us a little bit about that?
Yes, I did. So it was a remarkable series of events from my professional career development point of view, because I did get an opportunity of completing what was then required as an internship, 6 months of medicine, 6 months of surgery at St. Vincent's. And I can remember very vividly the opportunity I had to work as an intern, because just at the time I was starting, there was a newly appointed physician to St. Vincent's and to UCD, Prof Fitzgerald, who had just come back from Boston. He had been there for a few years working with Ed Gainsler and others at Harvard. And I can remember very vividly one evening in the cafeteria at Vincent's, seeing him eating dinner, and I took up my nerve and went over and asked him whether I could work with him as an intern for 6 months. And very fortunate for me, he agreed. And so my first 6 months was working with a colleague, Patricia McCarthy, who was the other part of our team, and we were Mauritius' very first interns at St. Vincent's. And in fact, that was a game changer for me, because my career subsequently was very largely determined by my efforts to emulate Murish and what he was doing as an academic physician and a respiratory physician. Part of the reason, in fact, I decided to do respiratory medicine as my specialty.
And your other house officer jobs around Dublin, or did you work as a registrar?
No, I finished the intern, 6 months of medicine, 6 months of surgery, then spent a year as an SHO at Vincent's, 6 months of that working with the professor of medicine at the time, D.K. O'Donovan, and his team, and then after that made a decision to relocate to Canada.
And what was it that led you to choose Canada and Ontario? Or?
Well, at the time in Ireland, very different to today, I know, there really wasn't well-organized and well-constructed clinical training in medicine. And so if you wanted to do that, you had to make a decision to leave Ireland for a period of time, and the expectation, at least in my mind, was to return. Now, I had recently been married shortly after I graduated, a year or so after I graduated. And my wife, Irene, had a large, very closely knit family with 6 siblings and herself. And one of these siblings, the eldest one, had immigrated to Canada a couple of years before. So Irene wasn't thrilled about the opportunity of leaving Ireland, but did agree after a bit of negotiation that we could go away for a year. And the obvious place was to go somewhere fairly close to her sister. So we focused a little bit on medical schools in southern Ontario, as Barbara was living in Toronto at the time. And that really limited me to two choices, University of Toronto or McMaster University. And I applied to both, was fortunate to get accepted into both, but made a decision to go to McMaster. And that, again, was a very fateful decision for me for the rest of my career development.
Sure. And in terms of your choice of respiratory medicine after your general internal medicine training, I guess you've touched on it already, that Prof Fitzgerald had an influence on you as a role model. And were there other role models subsequently that led you down the respiratory medicine route?
Absolutely. And again, tremendously fortunate when I look back and think the way things develop and the decisions one makes based on the kind of mentorship that is available and that is so important to a young person developing their career. At McMaster, when I came here, it was a very interesting place to come to because at the time it was Canada's newest medical school. It had been the first medical school class was actually enrolled in 1969, actually the same day that I had started pre-med in September 1969. And the medical school was a very unusual place in that when they began, way back then, they decided to completely dislocate and reassociate the procedures for medical education. So the decision was made to, first of all, have graduate entry, which was fairly well established in Canada at the time, but I certainly did not experience that in Ireland back then. The second decision that was made was to change the medical curriculum to have a 3-year rather than a 4-year curriculum, although it was a very condensed curriculum, very little time off during that 3-year period. And they were the first school in the world to introduce problem-based learning, small group problem-based learning to medical education, and also had decided not to have any formal examinations during the 3 years of the medical school curriculum. All the evaluation was done by continual assessment, and there was, of course, at the end of the training, a period of, there was a licensure examination that was needed, that was taken by all Canadian students, but that was the only examination that the students had. So this was a very interesting and very risky experiment in medical education. So I arrived in Hamilton at McMaster. This was about 8 years in and was still considered to be quite an experiment, which has, I'm sure you know, has turned out to be an immense success. But one of the people that had been recruited early on to help develop this medical school was a man called Moran Campbell. And Moran Campbell had been recruited from the Hammersmith in London and was one of the great names in respiratory medicine at the time. He had developed the science around controlled oxygen therapy and had really changed the way that people in respiratory failure were managed. And he was the very first chairman of the Department of Medicine at McMaster. So when I arrived here, Moran was here. He had also brought in a man called Norman Jones, who was the doyen for exercise physiology around the world, and a third individual called Freddie Hargreave, who did become, for me, a critically important mentor in developing any interest that I might have in research. So the fact that they were there, mainly by happenstance, turned out to be, for me, a tremendously important career opportunity.
Okay, and can you tell us a little bit about life in McMaster, work-wise, in terms of, I guess, outside of COVID times? Obviously, everything is turned upside down at the moment, but before COVID arrived on us, how's the working environment there?
So McMaster was, way back then, and still remains, a very interesting and very enjoyable place to work, Michael. It began, as I've described, as a place of tremendous innovation in medical education, and recruited people to the university to the medical school that really were interested in pushing the boundaries, both in medical education and in research. And it's continued to this day, very much like that. We are very fortunate in many ways. The medical school and the city we live in is a really terrific size. It's not too big. The city is about 600,000 and our drawing population for medical care about 2 million. But it's not too small. So the medical school is big enough to have lots of specialties, of all the specialties that one would have, but tremendous ability to engage, collaborate in a collegial way. And I've really enjoyed that immensely. It's made a big difference to my own career growth and development, having that kind of a very collegial and engaged environment. And we've tried to maintain that up to today. It's been a bit of a struggle from time to time, but I think mainly we've managed to keep that ethos that it was so important when I started.
Sure, and life outside of work in Hamilton, can you tell us a little bit about that? Are you able to still keep in touch with your old rugby roots in Ireland, or have you taken to ice hockey altogether?
No, not at all. Life in Canada has been wonderful. Aaron and I have settled obviously here. We had planned to stay a year, stayed 2 years, and then 5. Then we went to California for a couple of years to UCSF, where I did a postdoctoral fellowship, which was another fabulous experience. We have 3 children born here, all of whom are thriving, doing well, all married. We have grandkids, and so life has been very positive, and it's been great in Canada. I do miss part of being away from Ireland, but I keep very close touch with the rugby, Michael. We are lucky with the streaming services now that all the games are available. I still follow Leinster Rugby Club very closely, watch all of their games, usually a bit delayed, but still try and keep in touch. And we'll be following very closely the upcoming Six Nations tournament, which starts, I guess, in a little more than a week from now. I've not really taken to ice hockey. I have trouble following the puck very closely, so I've been to a few games, but haven't really embraced it the way I have kept my interest in rugby.
Sure. And could you maybe tell us what highlights from your career kind of come to mind?
I've, again, been tremendously fortunate when I look back and think about the opportunities I've had and the time that I've been working both as a clinician and a researcher in respiratory medicine. As I said earlier, Michael, the opportunity to work at McMaster has certainly been one of the highlights, and the mentorship that I had from Freddie Hargreaves and others in the city has been just extraordinary and very impactful for my career development. I mentioned also we went to San Francisco, Aaron and I, and our little daughter at the time, Sarah, and spent 2 years there. And again, by just sheer happenstance, I was working in a lab with a mentor, Jay Nadell, who was a wonderful character and a tremendous scientist, but happened to be there right at the time for that 2-year period when our understanding of asthma changed completely, largely due to research that was going on in San Francisco at the time. Prior to me leaving, there was a tremendous focus in asthma on bronchoconstriction and the reasons why airways constricted more easily and to a greater extent than non-asthmatics. And indeed, that was much of the work that Freddie Hargreaves had done, making measurements of how twitchy the airways were, measuring airway responsiveness in asthma. In San Francisco, it was a more basic wet lab environment. It worked with animal models, but for the first time, evidence was collected to show that, in fact, asthma was an inflammatory disease of the airways. And that really had never been a focus of research before. And the research that I got involved with, working with lots of friends and colleagues who I still am very close to, even all these years later, demonstrated, I think, unequivocally that the changes in the hyperresponsiveness or the twitchiness of the airways was a direct consequence of inflammation. and that you could turn on this inflammation in certain circumstances and make the airways more responsive, and you could turn it off in certain ways, and the airways became less responsive. And ever since then, my research focus has been entirely on the mechanisms of inflammation in asthma, in asthmatic airways, and also how one can best manage those. And it all came because of that remarkable opportunity I had with Jay and with others in San Francisco. I think coming back to Hamilton, when I was ready to take on my first faculty position, the other highlight for me was the fact that there were people here who were very willing to take interest in my career and give me support and help. Because, as you know, Michael, you're a very successful clinical scientist, and you know the challenges that occur when a young faculty member is trying to get off the ground, get those first grants, and get the first papers published, and begin to create a bit of a career. And getting the support and collaboration and help from people here, Jack Hirsch and Jack Goldie and many others, was just critical to my being able to sustain a career as a clinician scientist.
Okay, and what would you say, Paul, were the biggest challenges you encountered over your career?
There were lots of them, Michael, lots and lots, as I'm sure would be true of anybody where they ask the question who have tried to build a career as an academic clinician. The first one, I think, was just the trying to balance one's life, because it became, or could become, all-consuming, trying to manage the clinical side, clinical care part of one's career, with developing a lab, writing grants, trying to get papers published, as well as having a young family and trying to manage the personal side of life. I was very fortunate to be married to a woman who was willing to take on a lot of the responsibilities of managing the children, raising them, because I was away a lot, both at the university, but as well as traveling. And again, I know you know this, the amount of travel needed to develop a career and to try and get a profile internationally for the work that you're doing. So all those were challenges which, I think exist for somebody starting out. And I think one of my main responsibilities now, as I see it, is trying to help and support people who are trying to do that here at McMaster, to try to emphasize that while the challenges are very real, the opportunities are fabulous, and the life we lead as clinician scientists, academics, in my view, is absolutely the best job one could ever have.
Yeah. And finally, what are your thoughts on kind of the future of medical education, both medical training after graduation and also undergraduate medical education, being where you are at kind of one of the centers of innovation in medical education? And I guess the answer to that might have been different a year ago than it is now, but how do you see training developing or evolving?
That's a great question, Michael. And the one thing I perhaps wanted to say, which gives me a chance to say it now, is that one of the great strengths, I think, of the medical education I received in Ireland, which I'm not sure is quite as strong here in Canada still, even today, was the clinical exposure that I had and the focus on the highest quality clinical training. So I was really pretty good at that when I arrived here, and I have found that over the years that I've been here, that many of my colleagues, and we've had a number of extremely successful Irish graduates who have moved here to Hamilton, who have been here at McMaster, trained here, have gone on to do great things. People like, Kieran Killian was here before me, but Jerry Cox, who's still working with me here as a colleague, Mark Fitzgerald, Clive Kieran, and then a whole bunch of people that came when I had a lab established, Terry O'Connor, Des Murphy, and Patrick Mitchell, who, by the way, is just going back to Ireland, I think, in the next couple of months. And a wonderful young woman that's here with me at the moment, Ruth Cusack, as a clinician working in the lab. these people are consistently outstanding clinicians and very, very comfortable in the day-to-day clinical management of patients. One of the limitations of the medical education program that I work with and live with here in Hamilton is that it's very condensed. It's a 3-year program, or other programs in Canada, 4 years, which is usually 2 years of sort of preclinical and 2 years of clinical training. Means that the opportunity for students to get the exposure that I enjoy to the breadth of clinical training, I don't think is as good as it was, for me at least. So that's one issue that we've talked a lot about here at McMaster, how to try to improve that exposure, because a lot of it is indeed just the exposure to patients, the opportunity to see a variety of conditions and to work with very accomplished and skilled clinicians in dealing with these patients. Another big change for me when I came here, and I think is maybe even a little worse now than it was then, was the fact that these young medical students here in Canada need to make decisions about their future careers very, very early in their career. So when I was at medical school, I was convinced I was going to be a pediatrician. 6 months working with Prof Fitzgerald changed that for me completely. And I decided to do medicine and then respiratory medicine as a result of that. But here in Canada, the decision needs to be made at least a year before the student finishes their medical training, because they have to apply to what's called a CARMS matching system, which matches the student with the training program. It's very competitive, and for the top programs, it's extraordinarily tough to get into them. So the students are very focused on their future career, in my view, very early on in their training, and I'm not sure that's necessarily the very best opportunities that they have to make the right decisions in relation to their career development. The other thing that's changed quite a bit, of course, is the postgraduate training systems. We have a very excellent series of postgraduate programs in Canada. Canada is very well known for the quality of its postgraduate medical education. We have moved recently to what's called a competency-based type of training, which has been, I must say, quite a challenge for many programs. It is meant to identify weaknesses early on in training and potentially allow the very best postgraduates to finish a little earlier than they normally would through a fixed time program of 4 or 5 years of training. It is, however, a lot of additional work on the physicians and the mentors of the programs, and it's as yet, in my view at least, unproven to produce physicians that are of higher quality. So that's still a little bit of an experiment, I think. And I'm not sure whether that is yet in place in Ireland, but I suspect it might be sometime in the near future, and carries with it, I think, potential benefits, but also a bit of risk associated with the costs and with the potential outcomes for the young physicians.
Okay, thank you, Paul. So I'd like to now just introduce Jane Curtin, who has been busy behind the scenes all week organising all of this, and I think she may have some questions from the audience to pass along to you, Paul.
Thanks, Professor Keane. Thanks, Professor Keane, and thank you very much, Dr. Byrne, for being so generous with your time and all the information and views you've shared with us. Yeah, we have some questions in from our audience. Maybe we'll start with the more fun-based ones. So one of our members of our audience would like to ask Dr. Byrne, does he have any hospital cup memories or any memories of having pints in Hortos after the matches?
I have. I'm probably not going to share most of them with you, but I have certainly good memories. I played rugby. I was not particularly accomplished as a rugby player, but I played a scrum half for a number of years, a little bit at Terenure, and then subsequently for the hospital. I don't remember the matches at all. I have no recollection whether we won any of them, to be honest, but I certainly remember the celebrations after the matches very well indeed. And I certainly miss that degree of camaraderie and enjoyment that those rugby games allowed us to have with both the team, but as well as the opposition. Playing against the Mater, for example, was one that I have a particular memory of.
Good. And one of our audience members was very interested in your approach to Professor Fitzgerald and asking him, could you be his intern? So they were wondering, just if you could expand a little bit more about your time in St. Vincent's and your time working on Professor Fitzgerald's team.
Yeah, I'm happy to do that because I have very, very fond memories of that time. And also of the experience of working with Maurice Fitzgerald. He was, I think actually still today, is probably the best clinician I have ever seen. He was very, very knowledgeable, first of all. He knew everything about every medical condition. But he was an immensely compassionate physician. Very, very focused on patient, but also the patient's family, and how one approached the patient, discussed with the family, and I just was so impressed by his empathy and his engagement and how he managed that. Patricia McCarthy was my co-conspirator in those days, and she and I had a terrific working relationship. We had a number of SHOs coming through the program, so it was just a fantastic experience. I also remember very fondly the quality of the care the patients received in Vincent's. I hope it's still the same today. I suspect it is, but the quality of nursing care particularly was just exceptional. I've never seen it actually matched in anywhere else that I've worked in, either here in Canada or in the United States. The hospital, of course, was run by the Little Sisters of Mercy, and each of the wards had a matron who was, I think, mostly a nun, and they ran the place like with an iron fist. But the care and attention that the patients received was quite exceptional. So it really got me off on the right foot, I think, in thinking about how to be, first of all, a well-rounded physician, but also one that was very focused on patient care, patient outcomes, and of course patient families and how they should be engaged in the patient decision making.
Thank you very much. And we have a question here which will bring you back to your college days, but one of our attendees would like you to share some memories from your undergraduate lectures and the lecturers.
So a couple of things come to mind in relation to this, Jane. One of those was the very first day of pre-med. This actually happened. It sounds almost hackneyed to say it, but there were, as I think, something like 240 or something like that, some number of students entered pre-med with the knowledge that only, I think it was about 100 or so would actually end up in the first med class. And I can remember us getting together in an auditorium and the professor of medicine at the time, D.K. O'Donovan, coming in and telling us that we should look to our left, look to our right. You know that old story, there's only been one of you here a year from now, so make sure you make best use of this time and give it your very best shot to get into the first med class. I actually had thought about bringing with me a memento of those days. I actually forgot to do it, so I haven't got it to show you. But I can also remember when we had finished pre-med and we're entering first med, the opportunity to purchase the Faculty of Medicine scarf. Every faculty had its own scarf, and that is how you were identified as being a student in medicine or in one of the other faculties. And I still have that scarf. It's at home, and as a reminder of the sense of success and achievement of actually getting from the pre-med class into that first med class. Of course, all of the learning in the first 2 preclinical years was lecture-based, and I don't remember much of it, to be honest. And that's, I think, part of the reason that when the founders of McMaster Medical School decided to develop a new program, they decided to eliminate lectures. So we don't have lectures at McMaster. We never have. Everything is done in small group problem-based learning because of the pedagogical research that demonstrates clearly that one doesn't remember much when you sit in a large lecture theatre, and that's certainly been my experience.
So the questions are flooding in now, and lots of compliments to you. The next question is, you described how your career progress has been assisted by inspirational mentors and a collegial environment. How can our alumni around the world provide the path for current, how can our alumni around the world provide this path for current medical students?
That's a wonderful question, and thank you for asking it. I cannot stress enough how important mentorship was to me. I had 3 great mentors in my career, and I was immensely fortunate to have them. Prof Fitzgerald to start with, Freddie Hargrave, who really got me into believing I could do some research that made a difference, and then Jane Adele in San Francisco, who really taught me that the question you asked was the important thing, and research is all about asking the right question. And without those mentors, I would not have had whatever success I've achieved is because of the mentorship I received there. And I think that being a good mentor is a lot of things, and people are have different ways of doing that. But for me, the most important thing wasn't the closeness of the mentor or the willingness to sit and chat and have a coffee and discuss problems. It was much more the fact that they walked the walk. They did what they thought they should be doing, and the response to me was to try to emulate what they were doing and to try to match, if you like, in a way, the success that they were achieving. Of course, being available to people and having a chance to discuss career development and career opportunities, and being there when individuals are struggling, as we all will in these jobs, with failure in grant applications and papers not getting accepted for the 4th or 5th time and these kinds of things. Being available is really important. But for me, the critical thing in mentorship is to be a role model, to show the young people that you can succeed. You do need to be persistent. You need to have a willingness to work hard and to put a lot of effort in. But at the end of the day, the job is really worthwhile.
Okay, excuse me. Before we get on to the next question, there's just a little interlude here from Fiona Robinson, and she says, "Great to watch you, Paul, and hear your story, which we are so proud of. I'm proud of what you have achieved. We are toasting a glass of Chateauneuf de Pape in your honour." And that's cheers from Fiona and Ger, and they're your Irish wine buddies.
Oh, excellent, excellent.
Yeah.
As always, a wonderful choice of wines.
So on to the next question, and this question is, Forbes Magazine just recently ranked McMaster 23rd out of 300 best employers in Canada. Do you take pride in such a high ranking? And how has McMaster Faculty of Health Sciences contributed to this ranking, in your opinion?
Wow, that's a terrific question. Thank you. Yes, of course, we're all very proud of the rankings that McMaster has achieved. In the most recent issue or release for the Times Higher Education ranking for health universities and medical schools, we are ranked 11th in the world, so just outside the top 10. And for a relatively small medical school in a medium-sized city in the middle of Canada, that's makes us all very proud. And of course, it's external validation of the fact that this is a very innovative place and I think does very interesting things. The university itself in the Times Higher Education ranking is ranked 70th in the world. And that, in my view, is largely as a result of the success of the medical school and the Faculty of Health Sciences. We have a School of Nursing, a School of Rehab Sciences as well, all of which are really very successful. The nursing school ranked 16th in the world in a recent evaluation. So now the rankings can fool you. You can think you're doing much better than you are, and of course they are only one metric, but one that is always reassuring to see that at least some people externally think that you're doing pretty well.
Okay, excuse me, thank you for that. The next question is Dr. Byrne a fan of problem-based learning, or is there still a role for old school traditional learning in medicine?
Yes, I think there is. And in fact, quite interestingly, the founding fathers of McMaster University were very, very focused on the use of problem-based small group learning in the medical school. But of course, over the years, it has morphed and developed and being modified into something that is perhaps a little less rigid in its application. So in fact, nowadays here at McMaster, we do have, for example, examinations, although they are OSCEs, these small examinations that people run through stations and you deal with specific problems in a short period of time. And that was largely done because the students wanted it. They needed some validation of how well they were doing during their time here in the medical school. As I mentioned earlier on, I continually worry about the extent and qualitative exposure to the clinical side of training in medicine. I think that was exceptional in Ireland, in my experience, and as I've said earlier on, the quality of the Irish graduates that have come here to work in Hamilton, and those I know across Canada and elsewhere, they're wonderful clinicians, very accomplished and well-rounded clinicians, and I think that's in part because of the extent of the clinical exposure we had during medical school. So a condensed program like we have does make that very difficult. And we are now rethinking that a little bit to see if we can extend how students get exposed and use other approaches like simulated, simulated learning laboratories to try to extend the clinical exposure as much as we possibly can.
Clearly there, just a follow-on question on that theme, but one of our attendees is very interested to know how you developed your lecturing style.
I have no idea, actually. Although I will say that one of the opportunities I had in San Francisco as a postdoc was to attend a course run by a man called John Coleridge, who is an English professor at UCSF. And this course was on how to give an effective presentation. And what they did was actually very clever, I think. This was way back in the 80s, and that there was a very small group, maybe 8 or 10 of us, and everybody had to prepare a 10-minute presentation, and it could be on any topic. It could be on your vacation, it could be on recent paper you read or your research, whatever you wanted it to be, but it had to be exactly 10 minutes. The lecture was filmed, was videotaped, and at the end of it, the lecturer, the individual, or myself when it was my turn to do it, left the room, and the other colleagues who were there discussed the quality of the presentation, not the content, but just the way the presentation was done and how effective it was, the individual was in presenting information. You then got a chance later that day to look at your own video, and I tell you something, that's a horrible experience when you've not done this very much and you see yourself giving a talk to colleagues on video. I can remember vividly my heart sinking when I was looking at that particular video of the presentation. But then the next day you got together as a group and you presented your interpretation of how it went and they gave you feedback. And I learned more from that experience than I think any other in relation to what makes an effective presentation. The quality of the slides, the way that the presentation's pulled together, but also the best way to actually present the information that you want to present. I've never claimed I'm any good at it, but any skills I have, I think largely come from that one opportunity way back then.
Okay. And our final question, which is turning all of our lives upside down, but one of our attendees would like you to explain a little bit about the Department of Health in Canada's strategy to contain COVID-19 and I suppose ultimately eliminate it. And then what advice might you give to our Department of Health on our strategy here in Ireland?
So I don't think any of us have done this particularly well, I have to say. Certainly we have not done it brilliantly well here in Canada. I think we have had some success. We decided very early on to try to limit exposure, obviously, I think like many places did, and we made a very early decision to, for example, shut down any face-to-face contact at the university I work at. So from about early March, the university went virtual, and it's remained that way up to today. Canadians tend to be fairly good at following recommendations, so the wearing of face masks very widely was accepted early on. Not having too close social contact, large gatherings, was accepted as a fact of life during the pandemic. But still, we've had lots of cases. We've had a second wave, I think, like they've had in Ireland just in the past couple of months. It looks like things are beginning to plateau now or begin to decline a little bit. And the next big challenge is an effective rollout of the vaccine. And I think like everywhere else, there is a lot of worry about the availability of the various vaccines that we have approved in Canada. And then secondly, how best to use these in the most effective way and around decision making about who should get the vaccines early versus late. I think by and large, the Ontario Ministry of Health has done a pretty good job in that regard. They have identified nursing homes, retirement homes, the individuals who are directly involved in patient care of at risk or patients infected with the virus as being the first group to target. That's going fairly well. But it's still quite a ways to go. Just today, there was an announcement of, again, a cutback in the availability of vaccines. So I think people, many of us, including myself, will now be waiting several months before we have access to a vaccine that I think is going to be the game changer. Looking at other places, we are, of course, very close to the United States. We are about 100 kilometers from the US border here in Hamilton. And it's been very disturbing to see some of the decisions made around public health issues in the United States and the impact of that. So I think there's going to be quite an active post-mortem of how we've dealt with this in Canada. I suspect in Ireland as well. And I think particularly in the States that appear to have made decisions that have been not necessarily in the best interests of people at risk.
Okay. So that concludes the questions, but lots of compliments and thanks to you and Professor Keane for your time and for organising this event.
Well, thank you very much, Jane. So I think now we want to present our medal virtually to you, Paul. So congratulations and many thanks for insightful, engaging and fun conversations. So I think we have a shot of the medal so we can see there. So congratulations, and we'll get that to you, Paul. And we look forward to having you on site, on campus in the very near future.
Well, Michael, thank you very much indeed, first of all, for taking the time to do this evening. This is an immense honor, as you know. Being recognized by your alma mater like this is something that I had never, ever expected would happen to me. And I'm just thrilled, and I feel very privileged to have this happen. And Jane, thank you for organizing it so well. I do miss being there in person. I've always hugely enjoyed getting back to Ireland. Aaron and I go back frequently, and we look forward to seeing you both next time we're there. Thanks very much indeed for this honour.
Thank you very much, Paul, and congratulations once again. So, just to everybody, thank you again for joining us, and special congratulations to Paul on this award, and thanks to him also for his time. We hope you all enjoy this important occasion, and we look forward to welcoming you to the second and the third events in the award series. The second event in this series will take place on Thursday the 25th of February, when the award recipient will be Sister Marianne Sina, award from the class of 1975. Sister Sina is a doctor and programme coordinator at the Faraja Hospice and Palliative Care Programme in Tanzania. The third and final event will take place on Thursday the 25th of March, and the award recipient will be Dr. John Donoghue from the class of 1967. He's a retired consultant nephrologist here in Dublin and also past president of the College of Physicians. So we will be in touch with invitations to these events in due course. So thank you to everybody, and thank you in particular to Jane for her time in putting this together. Good night.